So it's really my pleasure to introduce my mentor, Dr. Sheraz Daya. I did my cornea refractive fellowship with him 20 years ago. He's one of the pioneer and cornea refractive surgeon. He did a lot of work in stem cells. He's the first consultant did LASIK procedure in UK, but also introduced the film to LASIK. And I remember the intraLASIK was the first introduced by him to UK. Also the crosslink for keratoconus. He had a lot of invention and a lot of instruments. So it's really a pleasure to have him with us. We're going to talk about advanced keratoplasty. It's all yours, Sheraz.
Great, thank you. Well, thank you very much for that introduction, Osama. Thank you to the organizers of this conference for inviting me. I think it's quite interesting to have a Moorefields conference that's very international in terms of faculty, and I'm flattered to be involved. Yes, Osama was my fellow many years ago, and now I'm going to learn from him. Well, I have been learning from him too. So it's the way things go as we progress over time. So I'm slowing down, and Osama is gaining lots of speed. I'm going to talk about advanced lamellar techniques. You've already heard great talks from by friends and colleagues, Sadir and Rajesh, on the front and back of the corneas. What I'm going to be concentrating on is the shape change. Now, you've heard that lamellar techniques can be used for stromal opacities and also shape abnormalities. And I'm going to concentrate on a few shape abnormalities that are unusual and difficult to handle. So this is a patient who had a penetrating keratoplasty 10 years earlier, and he was sent back to us because he developed keratoconus again. They thought it was in the graft, and this is the early days of OCT of the cornea. You can see very clearly, although we can see at the slit lamp, but this is actually in the periphery of the cornea. In the periphery, the graft is fine. It's the rim that was getting thinner, so the cone had not been removed entirely. This is a wedge resection is an option for treating these conditions if it's well localized. It was described by Troutman, but Troutman talked about removing a bit of graft tissue as opposed to the host rim. Well, we decided to change that. The abnormal tissue, which is ecstatic, is in the host. Why not remove that instead of removing nice, healthy graft tissue? And that's what we did. Removed a wedge. This is the schematic of the procedure using a diamond knife and a pair of Webiner scissors to remove, and then suturing this down with. Initially, we used a combination of merceline and nylon. Nylon, as you know, is elastic, and the patient did very well, but regressed very quickly. So we decided to use merceline from there onwards. This is the same patient with 10 diopters of astigmatism preoperatively. And at 1 month, only 2.5 diopters of astigmatism left. What about this situation where you've got, again, the peripheral thinning, but it's really extensive and involves more than just a couple of clock hours. It goes, you can see here, this is horizontally on the left eye. You can see it's quite thin nasally and also temporally, and it also involves the patient inferiorly. The only area that is spared was superiorly. So what kind of options do we have? Well, you could do a wedge resection in this patient, 360 degrees, and that's exactly what we did. And this is the video which illustrates the procedure. We measured up the size, and we used a trephine to trephine the periphery outside the area that was thin. I'm going to move this along for the benefit of time. Well, here we have trefining the cornea, not to full thickness, to partial thickness. And once that's accomplished, then we dissect towards the graft-host interface. I'm using one of Melis's dissectors here that's used for anterior lamellar keratoplasty, and just very, very gingerly removing and separating that lamellar bit of tissue. We do this all the way around. I'm using a crescent here because there's a bit of fibrosis there. And without boring you too much, I'm going to move on a little bit. And we see we go all the way around 360 degrees. And once that's accomplished, then we remove the wedge of tissue that's abnormal using scissors, curved corneal scissors, and cutting fairly vertically. And that's kind of hidden there in the video. And once that's been accomplished, we then go ahead and we suture that cornea to itself. And that worked very, very well. It unfortunately flattened the cornea considerably, but over time, as the sutures came out, the cornea steepened up again. Another option is to do a deep anterior lamellar keratoplasty on a previous PK. And we did this, our first case was to try and beef up the whole cornea so we could do a central penetrating keratoplasty. But to our amazement, the patient did very well and developed 20/25 vision unaided afterwards, even with a cell count of 600. So we now do this as a standard procedure. It's a bit tricky. It's not for the novice lamellar surgeon. But you see we're dissecting the cornea in the periphery and then moving on. And this is a sort of layer by layer. You can't use a big bubble. It's a manual technique using Melis's optical recognition to identify how deep we are. And that works very, very well. And this is a patient, one of my first patients that I did. And you can see the old graft that's quite small, a 7mm graft that was superiorly displaced and had terrible peripheral thinning. And he's now almost 20 years out, and I see him on every couple of years, and he continues to do very, very well. So that's a deep anterior lamellar keratoplasty on an old PK. The rationale is they've tolerated those antigens for a long time. Who knows, if this keratoconus was a condition, they could have the peripheral endothelial cells may have migrated onto the donor tissue, keeping that cornea clear. If that's the case, then the chance of rejection is low. This was published in Cornea, and you're welcome to look at the results and our technique there. What about pellucid marginal degeneration? Rajesh has talked about a deep anterior lamellar keratoplasty as an option, and that is a good option for this condition. But I look at this cornea and I see a nice thick cornea in the center, and the only abnormality is in the periphery, it's outside the visual axis. Well, what if we were to tackle that tissue only? And we described a technique for doing this using a wedge resection and lamellar dissection for pellucid marginal degeneration. So this is basically what we do. We started with small amounts of pellucid, and then we realized we're creating striae in the posterior cornea, which interfered with vision. So what we do now is we identify the ectatic area, we dissect it and remove it. And then once we remove that tissue, or we could do that later, we dissect the cornea from above. So we use a Melis technique, dissect the whole cornea off, remove the wedge, and then suture it in. So this is a video created by my nephew that illustrates this quite well. So you got pellucid marginal degeneration. We make we cut out identify the wedge that needs to be removed, dissect off Descemet's membrane, take out the wedge, close it up with sutures, and then once the procedure is done, we inject air into the anterior chamber and push back the posterior lamellar again. And that avoids striae in the visual axis. And it's all self-tissue, so it heals very well without any immune reaction whatsoever. This is the actual procedure. So using a micrometer knife, that is one of the great things that RK brought to us, were all these tools for doing lamellar surgery. And so I'm making a cut. You've got to be a bit like Zorro to follow that line around. So that's the periphery, and then doing the area within. And once that's accomplished, we go superiorly. I'm making an incision using the same knife. I'm going to quite a deep level there. I'm using a paracentesis here to inject air into the anterior chamber. And that helps me identify, using Melis's technique, how deep I am. Let me see if I can move this along a bit. So here I'm taking off the wedge. It sort of peeled off, and often does when it's there's very little tissue there. And move this along a little bit. So I'm dissecting a little bit down below, and then from above. I'm using these little sputters here. I find it's better to use a Melis dissector to do this. And we basically dissect off the whole cornea. And once that's accomplished, we go ahead and suture up the wedge. So all the abnormal ectatic pellucid tissue has been removed. And we suture this with Merceline sutures. And I don't know why the video stopped. Now, this is what the patient looks like afterwards. Now, they really do look like they've got an egg-shaped cornea, but it does remodel and change with time. And in fact, what tends to happen is they actually start going against the rule. I try and avoid taking the sutures out. Just have to be absolutely patient. Eventually, they stabilize out. But what I have done with these patients is also cross-link them, because one patient in particular continued to change for years. And as soon as I cross-linked them, he was fine. So that's what I now do. Once I've done the procedure, I cross-link the cornea. So this is an example of one of our earlier patients where you can see that there's an incredible elevation, anterior and posterior elevation, with a high amount of astigmatism. This is post-operatively at 3 months with a marked normalized reduction in astigmatism and normalization of the cornea. And this is just some of our early results showing that in blue lines, blue bars here, the preoperative vision, and in the red bars, the post-operative vision, which is very, very good. And this is the visual outcomes best corrected. So can newer technology help us in some of these anterior lamellar techniques where we want to get away from behaving like Zorro with a knife? And we can. Some of the newer femtosecond lasers have OCT guidance. They're more precise. And you can cut circular cuts, elliptical cuts. It's all limited by software. And actually, femtosecond lasers can do whatever you like. We just have to get the manufacturers interested in helping us devise some of these techniques. They're more interested, the difficulties with getting approvals in the United States with the FDA and now in Europe with MDR, instead of limiting what we can do. So we have to use what we can with these lasers, and there are off-label uses. And so we fudge these things. And this is a patient here that came from Afghanistan to see me with extreme pellucid involving more than 6 hours of thinning. Now, this is far too difficult to manage a wedge manually. I didn't really want to do a graft in this particular case. And he also had recent high drops, as you can see right here. And he wanted to go back to Afghanistan within the next 3 months. So we decided to do a wedge resection on him. You can see the OCT here. It's sequentially very, very thin, 300 microns, 280 microns, 290 microns, 240 microns. And then you can see the area of recent high drops that was healing. This represents this area right here. So this is the video of the procedure. So we used astigmatic keratotomy cuts, and what we did was basically tram lines. This is the old Victor software. And let me go back. So the important thing is to do the central cut first. With a peripheral cut, you can always use a knife if necessary, but it's the one closest to the visual axis that you want to be as symmetric as possible. And this is what I've done here. So once that's been accomplished, and it's a 180-degree cut, let me go ahead and do the periphery. And again, here's hoping for the best. At worst, if it didn't cut through to the depth that we wanted, then we would at least have it scored. So I know with an outline and maybe some cuts, so we know where we're going. And you can see this. You can see that there. The vessels have bled. I'm making a paracentesis. It looked like a bit like a stuck record here, injecting air into the anterior chamber. And I'm using a freehand diamond there. And here I'm again dissecting that cornea. And this is a speeded up video. I'm not that crazy. This is a very delicate cornea here. And you can see I'm avoiding the area of recent high drops. I'll leave that to the end. So here I'm removing this. And if I'm pulling on that tissue, because it does separate. Now, if that perforates, I'm not really bothered, because I'm going to be suturing that area up and invaginating that Descemet's membrane into the anterior chamber. So here using Vanas to do some dissection. These are blunt-nosed Vanas scissors. And you can see that the periphery didn't cut very well with the femtosecond laser, but I can see the outline, and that's what I'm using as a guide to remove the tissue. And again, on the other side, now I'm going to the area, you can see that bubble just suddenly disappeared there a little bit, and you will see it go completely now. So there's a hole there where they had the pellucid. As I say, I'm not too bothered by it. I'm going to be suturing that cornea back to itself, invaginating that Descemet's membrane. And it looks terrible when you're putting these sutures in. You know, as I say, the cornea looks really egg-shaped, but you've got to believe it does work. It does correct the astigmatism. They're overcorrected to begin with, but it does ease up over time. So you can see the striae there, but once we've got all the sutures in, it looks a lot better. You can see there's a double bubble here. There's a bit of air in the graft in the posterior lamella, between the posterior lamella and the anterior lamella, and that will disappear with time. So I'm closing up all wounds, and that's it. It looks I've got rid of all the abnormal tissue, and this is just to show you what he looked like afterwards. And he was the one that kept changing, so I cross-linked him. So what I've illustrated here are some advanced Lamellar techniques. They're very useful in improving corneal shape and in turn vision, decreasing irregular and regular astigmatism. It requires a bit of experience. You're able to push the boundaries once you get used to doing Lamellar work. And the femtosecond lasers, I think, really are the way to go. It'd be great if manufacturers would help us do a lot more with these lasers so we can help our patients and make them more accessible as well. Thank you for your kind attention, and thank you again for inviting me to speak.
Thank you, Sheraz. That's very interesting. I know it's very challenging cases. Dr. Fogler, I'm afraid they have to leave because they had another meeting. So we'll open discussion. For this participant, if they have any question, please send their question. Dr. Sadir, will start with you about the endothelium keratoplasty. Here we found it a bit sometimes tricky, the view. You know, most of our patients not focus dystrophy, most of our patients really bullous keratopathy, very poor view, and we tend to do more dissect than DMAC because really it is more challenged cases we face. Any tricks to help us how to move to DMAC? Because many of our consultants here to do dissect, not DMAC. So,
well, first of all, it's a pleasure to be with you again. I miss my friend Sheraz Daya. We have missed each other now at many meetings. We give courses together and do wet labs at the academy. So Sheraz, hopefully we'll see you in Chicago, if not earlier in Europe. Osama, here's my take on this. If somebody's presenting to you with bullous keratopathy, and let's say counting fingers vision or 2400 vision, you know that with DSEC, you're going to get them easily to 2040 or 2050. You do not have to feel the pressure of doing DMEC on those patients. So if visualization is a problem, then you're not going to be able to strip Descemet's membrane successfully. Now, you may say, well, bullous keratopathy, some surgeons do not strip Descemet's membrane, which is fine, but I think it's been shown that the adherence of the DMAC tissue in an unstripped posterior surface is lower. So I don't think there's a huge need to do DMAC in these cases. DSEC is easier to do and will give you a good result. Now, if you are able to see these bullous keratopathy patients earlier in the course of their disease, for example, patient is referred to you after cataract surgery with corneal edema. You give it 1, 2, 3 months. It doesn't clear. Now, those are great for DMAC. I always peel off the epithelium. It makes it much easier to visualize. I use glycerin to defervesce the cornea. I also use the glycerin in my office for that purpose. So there are ways to clear your view. Most effective is removing the epithelium and the bully for that matter.
Thank you very much. Regarding the anterior chamber implant, as your case, when do you decide you need to remove the implant and replace it? And when you decided to leave this anterior chamber implant and go with the SEC or the MAC and leave the anterior chamber implant?
Wow, Osama, that's a big topic, right?
Okay, briefly.
But I'll cover it in 30 seconds. I'm a big fan of never leaving an anterior chamber implant in place. Now, that being said, many people will stand at the podium and say there's nothing wrong with an anterior chamber implant, especially if the patient has had a good vitrectomy, if the 4 feet of the haptics are sitting on the scleral spur, if there's no glaucoma. But that is rarely the case, at least in the patients referred to me. Here's what I would say to you. If the patient has a very good history of an anterior chamber implant, let's say placed in the early 1990s, has done well for 30 years, and slowly lost their corneal endothelium to the point that they developed corneal edema or bullous keratopathy, yeah, I don't think you should challenge yourself in removing that anterior chamber implant. You know they did not develop cystoid macular edema. They do not have glaucoma, assuming they don't have, or it's controlled by 1 drop or so on. I would just do a straightforward endothelial graft on that. And of course, a DSEC would be easier than a DMAC. However, if the patient had an anterior chamber implant and, they developed macular edema, you send them to your retina colleague. First, they put them on a topical nonsteroidal and a steroid. Then they give the peribulbar injection of triamcinolone. Then the intraocular injection of Kenalog. And then they put Ozurdex or an anti-VEGF agent. That's crazy, when the reason for their inflammation is the anterior chamber implant. So these patients, I think the anterior chamber implant needs to come out.
Thank you very much. Sheraz, about the... Yeah, go ahead, yeah.
Sadir, so tell me about the rho kinase inhibitors. Are these approved in the United States, or is it all off-label and imported under license through whatever means you have?
See, I know when Professor Daya asks a question like that, his mind is thinking of how can I figure a way to bring a product to market and take advantage of it.
No.
I'm teasing you, Sheraz.
I'd love to have it for the benefit of our patients over here, so I can do DWEC or DSO or whatever, even for those patients who have middling corneas but elderly, where I'd like to maybe boost them up a little bit.
So here's the deal. The only rho kinase inhibitor we have in America is Repressa, the brand. The generic is Notarsadil. It's approved for glaucoma. Some corneal surgeons are using it. It causes a lot of redness and inflammation. And if you talk to patients who've tried that, to doctors who've tried that and tried the COA product Glanatec, which is Reprosadil, most people agree that Reprosadil is a better product. So what we have done in America is we are not allowed to prescribe it to patients, but we tell them where to get it. And it gets shipped to the patient directly. It's very inexpensive. I'm talking about Glanatec, which is the brand for Reprosadil, and they get it from Singapore or from Japan. Costs about $250 for 5 vials. We tell them how to use it, but we are not the ordering physicians. And it's no problem getting it. It's available online.
I'll have to chat to you offline about that.
Okay. Sheraz, about the femtocataract for keratoconus, still using the side cut. Do you think the technology with the femto laser will help us to do better Dalk, complete Dalk procedure for keratoconus, or it's far away?
I don't think
other than the side cut.
It's a 3-dimensional cut, really, in keratoconus, for instance, unless you're flattening the cornea or applanating it. And the reference point that they've been using for cutting with a femtosecond laser has been the anterior cornea. That's a problem. What they should be doing is using the endothelial surface as a reference point. So it doesn't matter what the heck the cornea is doing above, as long as you're even right across the whole endothelium. And unfortunately, you can't get to within 100 microns of the endothelium, or you'll end up knocking off endothelial cells. So there are a few issues there. And I don't think I can't see that happening in a hurry. I'm the medical monitor for Bausch + Lomb lasers. So I know all the issues that are encountered in trying to get approvals. And I just don't see that happening in a hurry. But we can use a laser because it can cut the cornea quite well. We can use a laser for other things, as I described, for making selective cuts and removing wedges and crescents and so on.
About the blissed margin region.
Superficial anterior lamellar keratoplasty is good, but if you have an irregular superficial cornea that's deeply irregular, meaning there's big troughs and big peaks, you might not get the regularity across unless you've got a reference point that's the endothelial surface. So that's another issue. So if it's very superficial, that's great. I don't think you can do an anterior by using Rajesh Fogler's definition of SALK, ALK, and DLK. I don't think you can get a good visual result quickly with an ALK. Because we've done it, we've tried it, it doesn't work that well. And the DLK with the femto, I don't think it's going to happen in a hurry.
Osama, one comment. I'm sorry, finish up.
Yeah, please, go ahead.
Yeah, one comment. The analogous situation in anterior lamellar keratoplasty to the question you asked about DSEC versus DMAC, if a patient has very compromised vision, we don't, let's say a severe keratoconus ectasia, you don't necessarily need to get down to Dua's layer with a big bubble type 1. You can just thin the cornea down, and like Dr. Daya said, get it down with manual dissection or viscodissection down to 100 microns, and then put a graft on that. And Rajesh showed it very nicely. These patients are going to see remarkably well. They're starting with counting fingers at 2 or 3 feet, and now you make them 20/50, 20/40. There's nothing wrong with that. They'll be happy, as opposed to taking the risk of perforation with a big bubble, and then having to do a full thickness graft and risk the rejection and all the complications of that.
Yeah, especially patients who have, for instance, Down syndrome. They're not going to be driving Ferraris. They want to be able to see, and without. Sometimes they don't want to wear their spectacles, but if they've got a fairly flat, regular cornea, they're very happy and they can function well. So it's best to avoid taking a risk of perforating in those situations.
And about wedge resection, do you combine with cross-linking now for people who did wedge resection? So if you do wedge resection, do you prefer to do also cross-linking to stiffen that area, not to recur?
You mean
or blissed marginal degeneration?
Yeah. So I will once I've taken out the wedge and suture them up, once they've adequately healed, then I'll go ahead and cross-link them limbus to limbus. But covering the limbus with a strip of instrument wipe or chayet sponge, or to preserve the stem cells. There is some evidence to show that you can change the DNA, and the worry is you'll give them a neoplasm following cross-linking. So it's worth considering. And I also do that in DALK patients. I will cross, if they're young, I don't want to find out later that they're going to have a bit of peripheral ectasia. I will cross-link them after about a year or so. Usually once the sutures are out and away we're going, I'll take off the inferior 6 clock hours of epithelium, use riboflavin, cover up the visual axis, and cross-link the periphery.
Regarding Dr. Sadir, about DMAC, the size of DMAC, you said is 8, 7.5, and 8. Is that right?
I use 7.75 millimeter donor graft, and I strip about 0.5 millimeter more. So I strip about 8 1/4, 8 1/2. Professor Cruce's work in Erlangen showed that there's an advantage to overstripping rather than understripping. So you do not want to overlap the DMAC graft over host Descemet's membrane. That seems to work well for most surgeons doing DMAC, myself included. When Gerrit Mellis first introduced the procedure, obviously he's the father of all endothelial keratoplasty, and when he introduced the procedure many, many years ago, he talked as recently as 5 years ago about making a very large DMAC graft. And now he knows that that's probably not the best idea.
Is it rebubbling more for smaller or bigger, by the way?
You know, here's what I can say about that. There's no doubt that most people who do very large grafts say there's a higher risk of rebubbling. But I have no experience with large grafts, meaning larger than 8.5. I've been, for the last almost 10 years, used the same size, 7.75. But what is true is rebubbling in DMAC is greater than DSEC. That's a true statement. And every patient that I do a DMAC procedure on, I tell them on their post-op day number 1, when they look beautiful, of course, because you have an 80% bubble in the eye, that on the next visit, when they come 1 to 2 weeks later, there's a 20% chance that I may have to add more gas or more air to the eye. And I prepare them for that. And I no longer observe the Mellis rule. And I think Khaled himself has abandoned the rule where if it's only 1/3 detached, watch it. If it's detached enough that it's affecting the vision, they get rebubbled on the post-operative week 1 or week 2.
Thank you very much. I think we're finishing the session. So thank you for our distinguished speakers, Dr. Sadir Hanoush, Sheraz Daya, and Dr. Fogla. And thank you for the participants who attended with us, and looking forward to see you in person in next meeting. Thank you very much, everyone.
Right, thank you.
Good to see you all.
It's a pleasure. Thank you. Have a nice day. Thank you. Thank you very much. Take care.
Bye-bye now.
Take care.